evening, everyone. Thank you, everyone, for joining us online and here in person at the Fresno Center. My name is Sherry Cruz, and I'm the Director of Public Relations and Community Relations here at the Fresno Center. The Fresno Center is a nonprofit organization that assists individuals in becoming self-sufficient, self-fulfilled, and more productive members of the community while fostering preservation and promoting cross-cultural understanding. We are honored to partner with Zócalo Public Square to present tonight's program. I'll turn it over to Joe Mathers from Zócalo Public Square.
Thank you very much. I'm Joe Matthews. I'm the California columnist and democracy editor at Zócalo Public Square, which is an Arizona State University media enterprise. At Zócalo, our mission is to connect people to ideas and to each other. Everything we do is free. Everyone is welcome. We publish original writing and present conversations like this one. Founded in 2003, it's our 20th year. You can find us at zocalopublicsquare.org, on podcast platforms, and on YouTube. So please subscribe to our latest programs. We're excited tonight to be at the Fresno Center in Fresno, California's fastest growing big city, more people than Oakland or Sacramento, to continue our series, What is a Good Job Now? With the support of the James Irvine Foundation. Through public programs and essays, this series about workers in the low-wage sectors of California's economy explores how to make the hardest jobs more rewarding and make life better for those who do them. Tonight's program asks, what is a good job now in healthcare? I'm pleased to introduce our moderator for tonight's conversation, Cresencio Rodriguez-Delgado. Cresencio is the news director for KVPR, Valley Public Radio. He grew up right here in the San Joaquin Valley and has covered news for the Fresno Bee and PBS NewsHour. Cresencio, over to you.
Thank you so much, Joe. Hello, everyone. Welcome, and thank you so much for joining us today. So I'm Cresencio Rodriguez-Delgado, and I'm the news director of KVPR. And I'm excited to introduce our panelists today and get right into the conversation. So we have Janette Dill, who is the Associate Professor in the Health and Policy Management Division in the School of Public Health at the University of Minnesota, and the Deputy Director of the Consortium for Workforce Research in Public Health. Her research focuses on job quality and career mobility among the healthcare and public health workforce, and her research has been published in top public health and social science journals and has been supported by state and federal grants. And we also have Helda Pinzón-Perez. She is a professor of public health at Cal State University Fresno, and she has been a professor of public health for more than 20 years. Her areas of research include health matters of vulnerable populations, as well as health issues in rural areas. And last but not least, we have Martha Valladarez, who is an in-home supportive services provider. She has been married for 48 years and has 5 children. She was one of the first female letter carriers and female shop stewards in Fresno. And she is now retired after 34 years, but her youngest daughter has Down syndrome, which led Martha to join the Health Providers Union, SCIU 2015, for which she is currently the regional vice president. So we'll be taking your questions from the audience later in the program. If you're watching online, you can submit your questions in the live chat on YouTube. So with that, I think we'll get started. So my first question is for Helda. If you can really just give us an overview of healthcare in the San Joaquin Valley, can you explain an overview of how does healthcare look in the Fresno area?
Thank you, everyone. My honor to be here sharing with you. I would like to share some information from the Health Workforce Research Data Center, who created an annual report to the legislature. So this is the latest in January 2023. So you can always refer to that report if you need more information. First, Cresencio asked me to talk about some of the classifications for the health workforce here. And according to the report, the major groups of healthcare workers are in medicine, which include physicians, physicians, nurse practitioners, physician assistants, doctors of osteopathy, the area of nursing, registered nurses, licensed vocational nurses, oral health, the dentists, the registered dental assistants, and others, and behavioral health and allied health, which are a cornerstone of providers in the Central Valley. That includes clinical social workers, psychologists, educational psychologists, podiatrists, optometrists, as well as community health workers. I would like to refer you all to that report, and we can certainly share more on the report, but the key points of the report is that we need more healthcare workers, especially entry-level healthcare workers in rural areas, such as we find in the Central California Valley. There is expected to be according to the United States Bureau of Labor Statistics, an increase of 13% through 2031 in healthcare, in the healthcare industry. And when it comes to the specificities of the labor force, we see disparities in terms of the workforce being maldistributed in the San Joaquin Valley, and this comes from the report. And also a licensure data suggests an increase in exits from the workforce in 2021. That actually coincides with the decrease in the new licenses issue during that time. Approximately 35% of physicians are 60 years or more, and also we see an aging in the workforce in nurses and other health professionals. In general, I have more data, but limited time. So I would like to talk about the role of community health workers. And in community health workers, we talk about promotores, health coaches, health educators who have a major role in health promotion and disease prevention, which is one of the major needs in our area.
Absolutely. Thank you, Helda, for that. Janet, I'd like to go to you for the next question. You are visiting us from Minnesota, so it's a different place. But your research has focused on these places in the U.S. that have seen economies transformed by healthcare. And so we will get into the challenges of this area a little later. But can you talk about a region and the impact of healthcare in that region when it comes to the economy?
Yeah, well, I want to thank you for the invitation to be here, and I'm glad to be visiting from Minnesota. I think that I really started to think about sort of the transformation of our economy into really a healthcare-based economy when I was living in the Rust Belt part of our country, which is like Cleveland, Pittsburgh, Detroit area. And a lot of those cities used to be really manufacturing based. You know, if you think about like steel and automobiles, that was really the basis of the economy in those cities. I was living and working, I was teaching there at a state school, and a lot of my students had parents who would have worked in those industries, but they found themselves not having access to those jobs, right? Because those manufacturing jobs have really gone away. And instead, what really sustains those cities now are large health systems. So if you think about the Cleveland Clinic, right? It's like this mega health system. And it just is like this gleaming behemoth in Cleveland. And the same is true in Pittsburgh and many other cities. And so there's been sort of this shift from, a really manufacturing-based economy that really dominated up until the 1970s until today, where now the healthcare sector is the largest employer in the U.S. It employs more people than any other industry. So in many communities, not just in the Rust Belt, but in many communities, the healthcare sector is really the largest employer in town.
And we have somebody who works in health. Martha, we would like to kind of hear from you about how you got involved in healthcare. You said it was the last thing you wanted to do. So can you talk about what got you there?
Well, it was. I was a letter carrier, and I never expected that I was going to have a daughter with Down syndrome. My voice. And, I got to admit, I took it really bad. I cried. And then I realized, God's not going to give you something you can't handle. But then I found out that there was a union, there was help for kids with disability, and I wanted to learn more. And so one thing about the care provider union, we have a very, very strong union. So I wanted to get involved for the future of my daughter and for all the care providers that, so I knew that there was a lot that I could do and I could fight for. So one thing I wanted to see was time and a half. It went up to the Supreme Court. Justice Robert gave it to us. We wanted sick leave. We got 3 days of sick leave, which is really wonderful. Hopefully, I want to see us get a retirement, and we're going to work on that next. And we also fought hard to get a raise. It took us 9 years to get a raise from the county. Why? Because we elect the wrong officers. I can't believe that Riverdale, 95% of them are Hispanics and they're not going out to vote. He voted against us. And he had the nerve to say, I have my mother in a nursing home. And like telling me, why can't you? Us as Hispanics, we are going to take care of our loved ones. I said, that's fine. That's a tax deductible.
And we're talking about the Board of Supervisors
Yes.
in Fresno County?
Yes, those are the ones who give us the worst ones. And Nathan is another one. And I told them, we're 20,000 strong, so watch out when election comes. We just can't have that. And that's why it took us 9 years. We need a raise. We need at least $25 an hour. It's hard work. A lot of us cannot go out of the house and work. We can't because we can't, especially we have some kids that cannot walk, cannot speak for themselves. The parents have to fight for them. They're fighting for them all the time, and this is not right. So this is why I got involved. I made sure, to help every people that need help. That they don't know. They don't know that they could fight to get more hours. Like for example, for me, I was only getting 40 hours, and we would go door knocking to the north side of town, and every one of them were getting the max hours, which is 283. You go to the west side, this man, they lived in a one-bedroom home, and that was the bedroom with the living room and a little kitchen. He was only getting 40 hours. His son would go out on the streets and would get beat up because he had autism, and the father had to work. After work, he'd go looking for him, and he's beaten up. So he came to our union and says, can you help us? Can you help us? I go, I'll help you. He goes, no, I need a lawyer. I says, I'll help you. I know what you're going through. I'll help you. He goes, no, I really need help, but I need a lawyer. I don't have no money. I said, I help you. We appealed. We had to go 3 times. And the third time, the head of in-home support service wanted to talk to me. And I told her, you know what you do? You tend to profile people by the way they live, by their nationality. That's what you're doing. And you know what? She agreed with me. And you know what? He got the max, 283.
And
so we're there to help you.
And we're going to revisit more of your work in a little bit. But that gives us a sense of the challenge that exists when you're a health provider. So my next question is for Dr. Helda. Can you talk about you are involved with students who are going into the healthcare workforce. And so what should they expect and what has changed in these past few years?
Yes. Well, actually, I have in the audience lots of my students, and it's very nice to see them participating in these events in which they get the information they need to provide better care. In the students in public health, I also teach in nursing. So in these areas, they definitely are there with a vocation, with a heart that is willing to serve. But at the same time, the reality is that they expect salaries that are competitive. They also expect possibilities for growth, professional growth, personal growth. They also are looking for jobs in which they can have families, in which they can attend to the demands of other parts of life, not only their professional career goals, but also their personal, spiritual, social goals. They also are looking for opportunities to apply what they are learning to serve the community. In reality, I think our students are very much there because they want to serve the community and be agents of change that is going to contribute to growth in our society and improvement on the vulnerabilities that exist that improve social justice, equity, diversity, inclusion, and belongingness.
And we heard a little bit of Martha's story, Janette, some of your research has focused on healthcare. A large majority of those who work in healthcare are women. So, what does that mean for the way they're compensated and for the way that these jobs provide mobility?
Yeah. Well, I think one thing that I probably don't even need to say this, but I feel like a lot of jobs like home care worker or nursing assistant are really invisible in our healthcare sector and not acknowledged, even though they're a huge occupational group. So I was recently participating in a webinar in Minnesota, and I learned from one of the economists who was on the webinar that it's the largest, the direct care worker occupation in Minnesota is the largest occupational group in Minnesota. Over 8% of workers in Minnesota are employed as a direct care worker, meaning they're a home health aide or they're a nursing assistant. And I think the same is probably true in California. So there's a large number of workers who are in these occupations that are in large part very invisible within our healthcare system, and they are disproportionately filled by women, sometimes 80 to 90, 95%, and disproportionately filled by women of color and immigrant women. When we look at the wages for these jobs, they are lower than wages where there's more representation of men. So we would say that these jobs are devalued, meaning that they're not being paid at the same rate as jobs that are being performed by a mixed gender occupation, meaning both men and women together, or a male-dominated occupation. And I think it really speaks to the fact that women's labor is really undervalued in our society. It's largely invisible, it's overlooked, and it's not compensated at the same rate that we compensate men's labor.
And is there a sector of the population who works in healthcare who hold multiple jobs, who they don't just have the healthcare job, but to make ends meet, they work a separate job?
Oh, yeah, absolutely. I mean, as Martha described, a lot of these jobs are not, the workers might struggle to get full-time hours. They might struggle to get health insurance because they're only working part-time hours. And so what we end up seeing is workers take on many jobs, right? And they work across many different settings, oftentimes in the home, in nursing homes, lots of different healthcare settings in order to try and get enough hours to make ends meet.
And so I want to go back to Martha. What training did you get to be your daughter's healthcare provider?
No training. But you just take care of her they say, like your normal child. Well, of course, she's spoiled by everybody. But, treat her like you treat the rest. But it's hard for you to do it because she's special need. But I'm going to try not to cry. But what I learned, which I never learned, that these kids are treated different. And I ask when I do orientation, like when I take her out when she's just a baby, kids would just stare at them, and they would laugh at them. The parents are there, and it breaks your heart. Okay, like us Hispanics, when we see a beautiful child, what do? Let me hold that child. She's so pretty. I'm going to touch her porque le voy a hacer ojo. Don't we do that? But do we do that to special need kids? We don't. We don't go to the mother and say, can I hold her? She's beautiful. They never did that to me. And this is what you all should do. And we should teach our kids not to do that. And the adults to stop them from laughing at them. And this is what was the hardest thing for me. So please, when you see a child with special needs, go out there and tell them. Like my daughters and I, we saw a young lady, she's 21 years old, her daughter was Down syndrome. Once you have a child with Down syndrome, you can tell the child from Down syndrome. We go up to them and say, oh, she's beautiful. Don't worry, she's going to be fine. She's going to be able to do everything a normal child does. Like when my daughter went in the cabin, got some flour, threw it on the floor. If it would have been my other kid, they would have gotten a spanking. I was so happy that she did it because I said she did something normal. That's it.
And those are experiences that not many people get. Dr. Helda, I wanted to ask about the, we hear parents having to take care of children with Down syndrome. We also know that there is an aging population that is going to require healthcare workers, and so there's going to be a higher demand. So can you share about those demands and what are the gaps that we're seeing?
Yes. Well, first of all, I would like to express how in preparation to this event we have met and we have had the opportunity to hear the experience of La Señora Marta, as well as I am glad to see, like in this event, we have translation into Spanish, interpretation in American Sign Language. All these resources are essential to maintain a healthcare workforce that is effective. Having the investment in these resources is essential. Definitely more and more occupations, entry-level occupations are needed in healthcare work, in the workforce for the care of a population that is aging, that is living longer as well. We have populations with multiple diseases, we call it comorbidities, that also with polypharmacy, that means with multiple medications, and more of the care is extended to the home. Inclusive, I just recently read about how the concept of the hospital in itself is disappearing because now it's moving to train the healthcare workforce, to train the home providers with education that will formal education that will prepare them to provide the care at home, reducing hence the possibility of transmissions of disease, and leaving the hospital care for very highly complex needs and special care. Also, it's important to recognize the need for the healthcare workforce in rural areas, and I brought a couple of statistics about that. More than 46 million Americans, or 15% of the U.S. population, live in rural areas as defined by the U.S. Census Bureau. So the need now is for elder, mature, wise, golden age populations, and also in the rural settings.
Yeah, and a question for Janette. When you work in healthcare, there has to be exposures when you're in these different settings, whether you're at home, whether you're in the hospital, or whether you're somebody who's a janitor. So can you talk about that, and how does that factor into how this can be a job for someone?
Yeah, I think that that's a really important consideration. You know, sometimes when I was teaching undergrads, we would talk about how, healthcare workers are paid, and we would talk about this gender dynamic, right? And sometimes my undergrads would say to me, well, men deserve to make more. They would say things like this. It's just a picture into gender politics in the U.S. But they would say men deserve to make more because of the physical labor that they do. And, I'm not, certainly a lot of male-dominated jobs are very physically demanding. But I think we overlook the physical demands of a lot of healthcare jobs. And in fact, nursing assistants are more likely to experience occupational injuries and infection than any other occupation, especially during COVID, clearly. So, I think that there are a lot of risks that come with healthcare work, certainly for direct care workers, but for nurses as well. Occupational injury and infection are a real problem for RNs even as well. So yeah, healthcare is a really demanding demanding job, I think we overlook that part of it.
And when we talk about mobility and being able to move up, how does a pay factor into who can do a certain job, or who needs to stay where they are
Yeah.
instead of moving up? So it's a question for everybody. If you'd like to chime in on this question, but we can start with Dr. Helda.
Well, I would like to talk in relationship to that question about two things. One is the exodus of the healthcare entry-level workers. Because what happened with the pandemic is that the entry-level salary for service occupations was raised because of pressure. And but that didn't happen in the healthcare workforce. So we still have, for instance, home health aides, personal health aides with an entry-level salary that was the same as 2 or 3 years ago. So what happened is that they are moving from the healthcare sector to other service sectors, restaurant, hotel, etc. So in terms of the salary, definitely the salary has to be more competitive and reflect the growing trends of the labor force in general. Second, I would like to also mention that in healthcare, we have a lot of, we have personnel who have been highly trained outside of the United States, but they come as immigrants, and they take jobs that are in the healthcare field that are entry level. Many times we have doctors, MDs, registered nurses, etc., that may be working as medical assistants. And I want to emphasize the value of the entry-level healthcare workers, home health aides, medical assistants, dental assistants. All of them are the basis and like the pillars under which the healthcare system is structured. So they enter into entry-level occupations with the hope that they can find a way to that career development to go back to perhaps to the original job that they had in their home countries. With that said, that means that what is a good job in healthcare? Perhaps one that allows for that growth and that allows for the utilization of that knowledge into entry-level professions, and then allow for that professional development while still reestablishing, revamping the entry level.
And we can move on to another question unless you wanted to chime in on the question about mobility.
Yeah. Well, I was just going to ask Martha about how she feels about her pay.
Oh, yeah, you know, I'm one of the fortunate. I have a good retirement, but everybody else, I feel so bad for them. Oh, they deserve a lot more. And then there's this job that you know you're not going to leave it because you're taking care of your loved ones, so you're stuck. And that's not fair. We need to get those board of supervisors out of there. We need to fight hard. This is one thing that our union is fighting, and they're fighting hard. It's such a shame that we have to fight for what we want, and we deserve it. We work hard. A lot of us put in extra hours and not getting paid for them. That's what the providers do when they're taking care of somebody, and they know they need more hours. They only give them 4 hours a day or 2 hours a day, but they know they can't leave their patient there or the person they're taking care of. And they need help, so they put extra hours for them. And you cannot leave your loved ones and won't move on to another job. I mean, that's not human. But we deserve a lot more, and we're going to fight until we win.
There's a lot that the union is doing.
Right now,
So-
this is one of the best unions, because I was at the union at the post office, and they didn't even want me there because I was one of the first women. But, yeah, they said if I wanted to get paid like a man, I was going to work like a man. And I told them I pick grapes as nothing. But, you know, we have no choice what they pay us. But we can make a difference. We could fight. And on Tuesday, we're going to be at the Board of Supervisors. So we're going to be out there fighting.
So when we think of what is a good job, and you're checking off your boxes on where you want to work, and one of the ideas is you get to take a break from your work. We know Martha sometimes cannot take a break because it's a 24/7 job. But a question for Janette is respite care, this idea of respite care. So you can And Dr. Helda, if you want to chime in on this question too, this idea of you can leave your work at work and go home and take a break. Can everybody do that in healthcare?
Well, go ahead, please.
I would say, one of the challenges that I think there's a couple things. I mean, one of the challenges is the home care environment, right? When you are caring for a family member, it can be very hard to get respite. And another theme that I have heard from healthcare workers that I have interviewed during and after the pandemic is that, during the pandemic, there was actually a pretty good supply of healthcare workers because if you remember, we kind of have to go back in time a little bit, but if you remember, everything else was shut down, right? So there weren't a lot of jobs in other sectors during that time because all the restaurants were closed and retail and all of that. And so a lot of people ended up working in healthcare because they just needed to have a job. And so there was actually a pretty good supply of healthcare workers. So working during the pandemic was hard. This is what I heard from a lot of home care workers and people working in adult care homes and nursing homes. Working during the pandemic was hard, but really when it got really hard was after the pandemic sort of started to ease and the economy started booming, right? Like Helda talked about earlier, all of a sudden there was all this competition from other industries like retail and food service, and people started to leave. And then workloads became really intense in the healthcare sector, and there was a lot of pressure to take on, extra shifts and to stay late because no one was coming in after, and when you were there, you were taking care of extra patients because you were short-staffed. And so, I think that the issue of respite care is challenging, especially for people giving care to their families. That is being able to find someone to provide replacement care is challenging. But I think right now in the healthcare sector, especially for direct care workers who are working in nursing homes and home health, there's such a shortage of workers that the demands, the workload demands, and sort of the staffing challenges are really intense.
In terms of respite care and in relationship to what is a good care, a good job, certainly that's one issue that is constantly brought up by home health workers and entry-level health workers, is that they are expected to work whatever is needed because we are there with our hearts, right? So we, in all the professions, especially when there is a situation like we face of a pandemic, you kind of feel no right to say no. You have to say yes. And that happens with the home health workers, is that they have no time to take care of themselves, their mental health needs. That's one priority issue in terms of jobs, is allowing for mental health care for healthcare workers, because we ourselves are also dealing with health issues of various natures that require care. Also, another characteristic of a good job in healthcare is the flexibility, and here it comes the concept of telehealth and the digitalization of healthcare services. As we have more telehealth options, more possibilities for training, education to the entry-level health workers, particularly home health workers, training in, for instance, OSHA compliance, OSHA protections, Occupational Safe and Healthy Act administration, which provides training to the home health workers to also take care of themselves, prevent back injury, for instance, deal with mental health issues. I think that salary is an important component, but because in many ways we are with the heart, also the finding tasks that are rewarding and that are meaningful in our eyes as healthcare workers.
And when we saw the closure of Madera Community Hospital just up north, that is pretty much an entire workforce who couldn't go to work the next day when the hospital closed. And so that clearly probably sent signals to people who wanted to go into healthcare that it seems unstable. So Janette or Helda or Martha, whoever wants to answer this question, what are the solutions and who should be taking care of the healthcare industry, especially when you see a hospital close, or you see issues like entry-level jobs not being adequate. What are the solutions there, and who would you go to?
I'll talk from the perspective of academia, and certainly who should take care of the healthcare, the functionality of the healthcare system. That's a combined effort of communities, organizations, consumers, clients, and I will talk about the role of the academia as in universities or preparation educational institutions are to train diverse workforce. That reflects not only the diversity from an ethnocultural perspective, which is very important, very much needed, because that is a plus to have a workforce that resembles the population they serve, but also from the perspective of lifestyles, from the perspective of cultural aspects, like, for instance, communities, specific communities, in terms of lifestyles, in terms of, for instance, interpretation services in American Sign Language, in ethnocultural aspects, offer programs that are responding to the needs. I personally want to talk to you about the Community Health Workers Program that we are trying to promote, and I have seen it in several organizations in the Central Valley who offer certificates for community health workers. And what our university, California State University, Fresno, and the Department of Public Health is doing is trying to offer a venue for that growth, a path for community health workers to go into the bachelor's degree and then progress into master's or whatever other levels, because that is part of what we would consider a salary. It's not money, but it's definitely investment in education. So opening career pathways and dialogue among organizations to create those pathways together.
Janette, do you want to chime in on that question on who should be involved in making sure that healthcare is a good job to go into?
Yeah, well, I would say that payers have a big role in ensuring that the healthcare sector is operational and is valuing workers. So I think, when we think about hospital closures, a lot of that comes down to insurance, right? And how insurance is being paid out to healthcare organizations. So that includes Medicare payment policy, it includes Medicaid payment policy, and it includes private insurers. And I would say that all three of those are important in shaping job quality in the healthcare sector. They're really important in determining which healthcare organizations can stay open and thrive and which don't. And I would say all of them place a lot of emphasis on really technical, fancy, expensive care, physician care. And I would say that preventive care, population-based care, sort of the daily hands-on care is really undervalued by our payment system. If we think about the way our Medicare and Medicaid dollars are being spent, where that money is going, it's not being spent on direct care workers. It's not being spent on preventive care. It's not being spent on primary care. And it's not being spent on community hospitals, right? So I think a lot of it comes down to insurance companies and our Medicaid and Medicare dollars and how they're being distributed.
Interesting. And going to Martha for this question, there's 20,000 people in the union that you're a part of, and you've accomplished things like getting your hours bumped up or getting a higher salary. Yeah. Or getting paid more per hour. What else is needed?
You know what,
for
I
these
would
workers?
see a retirement. We accomplished a lot, but we really need a retirement. And thank God that they have a health insurance, but you have to have 80 hours. And they were trying to take that out to give us a raise, which we are not going to go for that. We need the health insurance. But that's That's what I want to see. And I want to see vacation pay. Right now, we have sick leave, 3 days a year. I want to see that, but I also, I want to see that and get paid a lot more. Get paid a lot more. We do the job because there's a need to it. And if we would get more pay, we would have more care providers, more in nursing home, because we're also in charge of nursing home. They're shorthanded. If they would get paid well enough, the clients would get better care.
And I want to add that I'm a quantitative researcher, so I use large data sets and look at, I use big data sets that are collected by the U.S. Census Bureau to study employment in the U.S., and that's the kind of work I do. And I never paid attention to unions until I became a quantitative researcher and started looking at workers' wages. And if there's one thing that consistently provides higher wages for direct care workers, it's unions. And it is consistently the strongest predictor of higher wages for workers. So I think that that unions are a really powerful lever for creating better jobs in the healthcare sector.
And we're going to end there for my questions, but we also want to open it up to the audience for questions. If any of you have been listening and you're curious about something that you heard, this is the time to ask questions. And I think we're going to have somebody come up here and you can line up.
Hi, everyone. So we'll get started with our Q&A. For anyone in our in-person audience who has any questions, please line to the right of the stage. Ariana will assist you, and then I'm going to start off with an online question. All right, so to our panelists, can the panelists point to any places, institutions, or programs in California that have done a particularly good job of making work better for direct care providers?
I appreciate very much the question and appreciate very much your presence in this event. Certainly, we place our students in so many organizations that welcome them, teach them the reality, and without their participation, our students could not get the experience that is necessary. So definitely organizations such as the Fresno Family Resource Center, Centro La Familia, Centro Oaxaqueño Binacional, para el Desarrollo Oaxaqueño Binacional, please excuse me if that's not exactly the title, but that center is serving the indigenous native communities that are coming from Mexico in the Central Valley and who are essential in the farm working population as well as in the healthcare field as well. Also because they also train and provide interpretation services in languages that we don't have many people trained for, Mixteco, Zapoteco, Triqui. Organizations, hospitals, and the hospitals of the Central Valley, I think they do a very good job. They do the best they can in terms of hiring people who resemble the diversity of the Central Valley, and I think I could name lots of them, but just a few.
Right, so our first audience.
Hello, I'm Lourdes Oliva. Thank you for such a wonderful conversation and very good speakers. So my question is, since you were referring to qualitative data, census data, I think the issue of immigration, I work with Siren and we service immigrants' rights. And if the data is showing the growing population of immigrants who are not able to leave or have family here because of the lack of immigration reform, how are we going to start preparing for that? Because, the baby boomers needed us. We were there. Now we need who's going to take care of us. So I think that how are you calculating or predicting, putting this information into your work? Because I think Madera is a good example of why that hospital went under, because we didn't see the data and the importance of the immigrant community that was there and how they had the lack of access to insurance, to education, to preventative knowledge, and also of practice of using healthcare. Thank you.
That's true.
Is there any response to that, to her comments?
Yeah. So, and tell me if I'm not answering this correctly, but it sounds to me like your question is, how do we care for the immigrants that are providing care for baby boomers and for people who live in this country? And I think that is such an important question. I think that, like I said, a lot of direct care work especially is really overlooked because it is being provided by immigrant women and other marginalized populations that we are not paying attention to. And so I do think that if we're going to talk about good jobs in healthcare, we have to think about, the whole healthcare workforce, including all of the people sort of who are not being seen. I think that as we've talked about, I think there are some levers for creating better jobs in sort of the lowest levels of the healthcare sector. I think unions are a really important part of that. And I also think that some labor policies around minimum wage, paid leave, health insurance, things like that can make a huge difference for immigrant populations. I do also think that, as Helda talked about earlier, I think that providing pathways for upward mobility within the healthcare sector can be really powerful. If we think about the difference between a nursing assistant, what a nursing assistant makes, and what an RN makes, it's an enormous difference, right? A nursing assistant is poverty level wages, and an RN is middle class, right, in the US. And so, helping people to make that transition through the healthcare sector can be one really powerful way that we can promote social justice and racial justice in the U.S.
Well, I definitely think that here is where we see the role of legislation policy that is supportive of a diverse health workforce, and that certainly revamps the debate about immigration, revamps the debate about training people who are already in the United States in health service occupations and allowing them to perhaps get a documentation status that will allow them to get into those professions in a full capacity, and also the role of the university's academia. And I don't know, I have this vision of, for instance, making sure that and we do have programs, health clinics, and various universities here in the Central Valley, because there are many who have programs with healthcare organizations in which they are going and train those health workers, community health workers. And when we talk about community health workers, we talk about health navigators, health coaches, community outreach workers, recovery specialists, family support workers, and now we are a new category is mental health care workers. Very important. So allowing workers in the home health field, for instance, to have programs, educational programs that are going to train them in the first place for better care delivery, but also to allow them for that growth.
I will add on the immigration issue that I think a lot of countries rely on immigration to support their healthcare services. So, specifically providing visas to bring people in to provide direct care work. Our neighbors to the north in Canada that does a lot more of that. We in the U.S. don't generally have that approach, but it's one that I see talked about more and more, just because of our sort of supply issues. So, I think that that is a conversation that we will continue to have with our aging population.
That reminds me of in nursing, specifically for registered nurses. There are programs where they bring registered nurses from outside of the United States, from Philippines, for instance, and there are whole programs established to train those nurses to pass the NCLEX, which is required for them to practice in the United States. They even have programs that are linguistic programs to develop the medical terminology, because we know it in our own original languages but may not know it in English. So develop the medical terminology knowledge that is needed, or also understand the culture and the healthcare system that is certainly complex in our eyes when you come from outside of the United States. We feel our home countries have very complex systems. When we come here, it's even harder to understand it. So all those components are feasible, not only for registered nurses, but they should be extended to other professions, and starting for the ones that are here already. I think they are here. Promote them, give them the possibilities to achieve that full potential that they have already by experience.
Awesome, thank you. So we have time for one more question, and this is an online question. So the American health system is famously expensive and not that good at outcomes compared to other countries. Can these entry and care jobs really be better within existing system, or do we need a new system?
Just a tiny question. 1 minute.
Well, there are several legislative initiatives to modify the healthcare system in the United States. I think the key point is to make a healthcare system that is more of health promotion, primary care, disease prevention. That will ultimately reduce cost in secondary and tertiary care. Also, definitely entry-level healthcare workers are trained to do that. That's why, yes, definitely they are a response to, if not modify the healthcare system, because may not be completely feasible to change everything in time-wise or in a moment, is certainly to strengthen the aspects of a healthcare system that are going to have the best cost-benefit, cost-utility results from an economic perspective, from a human perspective, that are going to really help people and that are going to increase the health status, the wellness of our communities, wellness from the physical, mental, social, spiritual, intellectual domains of wellness.
Well, thank you so much, Helda, for that response. I know we can go on and discuss this topic forever, but it's time for us to close, and really want to thank all of you for this conversation. It's been an honor to speak with each of you, and thank you to everyone in the audience for coming and listening. You will be able to find a summary of this talk at zocalopublicsquare.org by tomorrow, plus interviews with the panelists. And you can also subscribe to Zocalo's newsletter, podcast, and social media if you want to keep following. As Joe mentioned at the beginning, this program is a part of Zocalo's series, What is a Good Job Now?, which is supported by the James Irvine Foundation. And I hope that you all join us again in the future as the series continues. So Janette, Helda, and Martha, thank you again for the conversation, and please give our guests a round of applause.